substituting today. Very happy to be here. So we have two talks today, and I think it should be a very interesting hour. Our first talk will be by Chiang, and actually Anne's very much in the news today. Congratulations, Anne. So Anne is Associate Professor of Medicine, Medical Oncology, and Deputy Chief Medical Officer and Chief Integration Officer for Smile Cancer Hospital as of about 3 hours ago. She specializes in thoracic oncology with a background in translational research and metastases, and her clinical focus has been to build an amazing small cell lung cancer program here with a comprehensive portfolio of clinical trials testing novel therapeutics. Her research interests focus on development of clinical trials and translational studies to test novel agents and combinations with immune checkpoint inhibitors for both small cell and non-small cell lung tumors. Over now 9 years, and she's helped to build our SMILE network, which I think we'll hear about today, and oversees operations, quality efforts, and clinical research at our care centers. She has a particular focus in quality measurement and improvement, and has worked to achieve ASCO certification for the entire SMILE academic clinical practice. In fact, she received the Joe Simone Award just recently. Actually, Joe just passed away last week, but a big honor from ASCO. So Anne, it's a pleasure to have you here for our first talk, Transformation and Quality, Building a Cancer Network. Anne.
Thanks, Roy. It's really a pleasure to be able to talk to you today. And thanks for the invitation. I was trying to decide between lung cancer and the network, but because of the timing of the announcement this morning, and I thought that it would be nice to highlight the work that has gone into building a cancer network. So that's what I'm focusing, but I did put in a couple of slides with my trials, so I snuck that in. Okay, so I'm sharing my screen, my disclosures. And this is for if you recognize it, it's Southbury Terminal Farmers Market in San Francisco. And it's an amazing place because the quality of the food and the shops are really outstanding. I had the best peach I've ever had in my life. The atmosphere is buzzing and the shops are full of colorful, beautiful produce as far as you can see. And when I was here, which was pre-COVID, the last time, it seemed to me that this was more than a farmer's market where each farmer sets up their shop individually next to each other, but somehow there was a transformation of the individual stands into a different collective entity, a real community. And so in the same way that, I want to talk about our cancer network today. There really has been a trend over the past 10 years of academic institutions or other entities buying up practices or putting up their names on affiliated practices. But what I wanted to focus on is how I think we've built a real transformative network, a community that is better than the individual units, where cancer delivery is really somehow transformed. And so, let's go to transformation theory as a guiding principle for this work. As Cotter said, transformation is a process, not an event. And you start with a sense of urgency, form a coalition, and you create and share that vision. You empower others to act on that vision. You plan, create short-term wins, consolidate those advances, and hardwire new systems. And I think the bottom line here is that quality improvement methodology has really been the basis of my job in the network and formed the foundation of building our vision over the past almost 10 years. So the objectives for today's talk really are to, number one, provide a network development overview, describe quality concepts and metrics in network development, to discuss ways to further the research mission in the network, and then finally recognize the benefits of expanded community. So this is how it all began. When I started my job, this was in 2011, there was no network. We hadn't hired anybody, but we did have Yale SMILO, state-of-the-art disease-based patient-centered clinical operation. We had outstanding faculty, staff, trainees, cutting-edge clinical research, resources, and a cross-organizational commitment for expansion. and really a powerful coalition of folks to carry out that vision, which was really to provide comprehensive care to all patients close to home in Connecticut, and to provide a platform for Yale clinical research and expand access to trials. So this is really the result 9.5 years later. This is our clinical footprint in Connecticut and in Rhode Island. The stars are where our care centers are. And we do provide care to patients within 30 minutes of where they live in Connecticut. We provide care to about 45% of newly diagnosed cancer patients in Connecticut, and we also provide about, we accrue about 25% of therapeutic clinical trial enrollments. As Roy mentioned, we have achieved ASCO quality oncology certification throughout our entire network in the main campus. This is actually the only way to certify ambulatory practices. Many of you are familiar with the ACOS, which certifies cancer programs. And all of the physicians are YM, with the exception of Hartford, where the physicians are still St. Francis employed, but do have faculty appointments and are a stipend from Yale, and all of the staff are Smilo employed or leased. And we do have cross-system policies and procedures and quality initiatives. This is the timeline where I started here in 2011, and we did not have a network. And then over the course of the next 9.5 years, we brought in 8 practices, and in doing so, really had the opportunity to have multiple PDSA cycles in terms of improving our process and improving and perfecting our onboarding process. And now, as I said, we have 15 locations in 2 states. We have almost 50 MDs, 16 APPs, and over 400 staff. We see over 9,000 new patients, 125,000 treatment visits yearly, and the contribution margin on an annual basis is greater than 110 million. So I think that this has really been successful. And I'm going to talk a little bit about the onboarding practice, the onboarding process first. So this is where we really utilized integration and transformative change strategies to engage the stakeholders, the physicians, the staff in the practice. And the bottom line is that there's really no shortcut here. It really is hard work. Having regular meetings on transition issues such as Epic, pharmacy, workflow changes, and those transitioned into practice meetings, which were very useful are useful on an ongoing basis. We developed a formal onboarding curriculum, and this utilized leaders and peers as faculty, and it really included the Smilo vision and structure, faculty roles and expectations. What does it mean now to be part of Yale and Smilo? How does quality work? How does the research apparatus work? Who are the DART leaders? What does that mean? What are academic mentors? And so going through that curriculum, also involving team building and leadership training, and including our multidisciplinary members, not only med-onc and heme, but our surgical colleagues, our rad-onc colleagues, pain and palliative care. So the next item, or the next part of quality improvement, is really measurement. And this is a graphic of the really PDSA cycle. You have multiple iterations of how do you improve care, but measurement is really important. And so we started measuring at baseline because we wanted to make sure that we could measure progress and not just stick a sign on the door that said Yale Smilo. And this paper, published in 2018, really showed improvements in multiple domains of quality, including volume, clinical integration, quality metrics, and patient satisfaction. I'm going to show you a few of those, some of that data now. So in annual visits for chemo, this you can see the main campus in blue over the years, and then when the care center started in 2012, you can see the growth has really been significant, and we do give now more chemo in our care centers closer to home for our patients than we do in the main campus. In terms of standardization, we utilized COPI measurement. COPI is a program through ASCO called Quality Oncology Practice Initiative, and it consists of up to 90 metrics of oncology, of ambulatory oncology quality that have been developed nationally and are consensus-based and evidence-based when available. So we had a measurement at baseline representing the practices before they joined, and then this is 4 years later. We looked at the significant differences and saw that really the only changes were in the positive. These are actually shown here, and so this was really important to me because I wanted to make sure, again, it wasn't just putting a sign on the door, but that we were actually using national consensus-based metrics to show that we were improving quality for our patients. We also, as Roy mentioned at the beginning, did COPI certification across our network and the academic campus. This is similar to the ACOS certification. There are 26 standards, and you really have to show and document that the process from soup to nuts of chemotherapy administration and policies and procedures are in place that show that are up to snuff for ASCO certification. And we were certified in 2019. Regarding clinical integration, I'll just show you the, this represents cases care center cases presented at SMILO tumor boards. We have 13 disease-specific multi-D tumor boards, and we've asked all of our physicians to present 1 to 2 cases a month, understanding that we can't present all of them, but really those complex cases that need that multi-D discussion need to be presented. And so you can see in 2013, this was difficult because the logistics around dialing in, which is so easy now via Zoom, but at that time was very difficult. Getting the path reviewed, getting the radiology of diagnostic imaging to be available, that was really hard at the time. And now I think we've received, we've sort of, the steady state is right around 500. That's the case also, sorry, this is 2018, 2019, 2020, right around the 500 mark, which I think represents sort of the steady state. With respect to customer service, those of you who have, who pay attention to Press Ganey know that we always cluster in this 90s area. It's very difficult to make any changes here. But if you look at, again, baseline Press Ganey scores for practices that we acquired, and 6 years later, you can see that in all of the cases we actually stayed the same or actually improved, with one exception here is this D site. But in some cases really significantly improved patient satisfaction. This highlights some of the innovative projects that we've taken on in the network. This was a pilot with ASCO. ASCO has a quality training program that is 6 months and has 3 didactic sessions and a very aggressive curriculum every 2 weeks around process mapping and barrier analysis and ultimately multiple PDSA cycles. In this case, we had a team from every care center at the time in 2017, and we did it again in 2018, which were interdisciplinary teams. So we had doctors partnering with nurses or nutrition, or and in one case an MA, pharmacy, to conduct quality improvement projects. And all of those groups were able to complete at least 1 PDSA cycle over 2 years or each year getting through a PDSA cycle. And this work ultimately resulted in in 5 national presentations. And one of those projects that Jane Kanowitz led in Waterford in 2018 is actually the Care Center Quality Goal for 2021. I think many of the participants in these projects were really energized by the teams and what they learned around quality improvement. And one question was, how do we sustain that gain? You know, I think that it's important to be able to use those tools in QI to better care and recognize opportunities to reuse them to face challenges. And this is actually what we're doing now in the ambulatory transformation work group. We have a number of groups that are really using the same QI tools and change tools in lockstep action across multiple teams to respond to the pandemic and work towards transformation of care, whether it's relocation of sites or rapid uptake of telehealth, or developing and disseminating best practices. I think that this is the same process as the ASCO Smilo pilot, but now applied to the immediate COVID pandemic now that we're in. So I think you'll hear more about the work these groups are doing over the coming months. And I think it's been really exciting. So now I'm going to turn to clinical research. And as I mentioned before, we have about 25% of our YCC therapeutic enrollments from the care centers. This is also a process that needed to be built and hardwired. This is back in 2012. We had 3 cooperative group trials open, and we had to figure out how to do SOPs around drug shipment and lab processing and training the staff and the docs to do trials where they hadn't done that before, and as well as the PIs of the trials to make sure that they were comfortable and had oversight of the process. Over time, we developed a monthly clinical research working group that has research champions from each site that meet monthly and vote on their portfolio. The disease team leaders come to those meetings and present their portfolio and new trials. And I think that this process has really grown. Obviously here in the next slide, you can see that the accrual the yearly accrual by site, and the highest sites, St. Francis, North Haven, Trumbull, Fairfield. I think one of the things we've learned is that they need to have, or they have a CRSL lab, which allows all protocols, which means that there's no limit on protocols that they can open due to lab processing times. Certainly the 2020 accrual was affected by COVID. I think in in 2018, we had 224. This year, if you take out the months that we had COVID, and we had very good accrual prior and have really picked up now, we would have certainly hit 200, between 200 and 220, if not for COVID. So we activated a new site this year in Westerly. They are now treating some of the patients who were started in Waterford and now in Rhode Island. And you can see it actually in Waterford, which opened 3 years ago. There's been really great accrual growth there as well. So I think that there's really a lot of potential here. If the next slide shows you the yearly accrual by the DART, so which kinds of trials are having the best accrual, breast and GI are certainly at the top. The lung and heme are not far behind, as well as TRAD and GU that are increasing. So I think, again, there's a tremendous potential here. in the care centers. And as we have all of our docs aligning with disease teams, I think this will just increase in the future. This is the, I will quote Kurt Sabbath, who is one of our care center docs who helped to lead research initially, now handed over to Neil Fishback. Kurt always said that he felt that clinical research is synonymous with quality care, because there's so many eyes on the patient, there's so much emphasis on important communication, shared decision making, and that really epitomizes quality. In our case, the vision had always been to provide research access to our patients close at home. And I think that even more than the numbers per site, this is what really strikes me. Every year we have somewhere around 85 to 87% of our physicians who put at least one patient onto trials. So I think we really changed that culture. We've had a research summit every year, usually around 80 people. That includes our care center docs, our DART team members, our CTO staff get prizes. We have about 13 care center physicians who've served as PI on trials. And right now we have 83 trials open in 9 disease types, about 50% cooperative group, 43% industry sponsored, and 10% IITs. Here you see that our care center accruals form about 60% of our cooperative group trials, so that's really important. This is one of my trials. This is a national trial that we have opened in about, I guess, 900 sites across the US and Canada, but in our care centers as well. I'm national co-chair with Haas Borgai, and it's a first-line Ptl positive trial for non-squamous, non-small cell. And I think that this is an important trial because it either randomizes you to 2 arms which start with immunotherapy, and then if you progress, you go on to chemo, or you add chemo to the pembro upon progression. That's an important question. This is the chemo IO control arm, and this trial I think will tell us very important, give us information on sequencing of chemo, if you can spare it up front, if you add it to the immunotherapy, if that will help. And ultimately, because we are collecting tissue from this trial, we're going to be looking for prognostic signatures for pembrolizumab and predictive signatures for addition of chemo to immunotherapy. This is also an IIT of mine in small cell with a biopsy up front, and then on treatment at week 4 after treatment with Ipi/Nivo. And this trial has 17 patients who've started on it with 10 paired pre and on treatment biopsies. And this trial is open in our network, and we've had 11 accruals from our network. And I think that's important because talking to colleagues of ours across the country who have networks and who are trying to do clinical trials, they've really relied on industry-sponsored and cooperative, and very few actually have deployed IITs in the network. So this just shows you a number of the IITs that we have, and you can see that here's 12 accruals, or 30% of Dr. Lacey's modified FOLFIRINOX. And in this case, Dr. Kim Jo-Hung's, that's 88% of her, 7 out of 8 accruals for her. And for Dr. Naparidza, 40% of her accruals for her IIT as well. So I think this is really important research and support of our investigators at Yale. So what does the future hold? Among other things, I think there are certainly opportunities for building multidisciplinary care to enhance our SMILO signature of care in the network, and to build on our current Med-Onc and Hem-Onc, Rad-Onc networks to support and our surgical oncology representation. We are developing formalized multi-D clinics, and that's some of the work that I'm going to carry on in my integration role, and strengthen our alignment with disease teams and certainly our disease centers to provide service excellence and positive patient outcomes. This is my favorite slide. This is what I think is the most exciting piece of all of this. It's not numbers of patients, but really I think the faculty that have joined as care centers. One of them, Francesca, is going to give a grand rounds right after me. They have all are master clinicians. They have devoted, they're really the clinical arm of Yale Cancer and Smilo Cancer Hospital within the community, and all have joined with the disease teams to do, any number of really exciting things, be PI on trials, do collaborative research projects, develop QI projects, help teaching our house staff, and more. So it has really been my honor to represent these folks and to work with them. And I can't emphasize enough that it's really been a work, collaborative work of many, many, many hands to build the network, including Charlie and Lori, Kevin Billingsley, Kim Slesser, Art, LeMay, Lisa Chomsky, Monica, Fradkin, Connie Engel King, Roy Herbst, Stephanie, Helene, Kevin Best, and so forth. Jeremy Kortmansky will take over as the Chief Network Officer for Medical Services and head up the MedOnc and HemOnc, and I will be focused on really developing the service lines and integration with our delivery care network. So thank you for the time, and I think I'm done. So I'd love to answer any questions if there are any.
Thanks, Ann. That was wonderful, and congratulations on a very well-deserved promotion, and we see why. So we have a few questions. Please put them in the chat. Melinda Irwin comments, we're lucky to have this infrastructure with the care centers. I know a lot of non-therapeutic interventional research being done in the care centers related to tobacco control, nutrition, exercise, and obesity. So I will just follow up and say, Connecticut's such a diverse state as you go up and down the 95 corridor. How are we trying to help increase the diversity of our patient population at our care centers to get more patients from diverse backgrounds on trials? That's certainly something that we can now do, that we have so much integration within the state.
Great question. I'm just going to go back and share my screen again so you can see who's doing a lot of this work. Melinda, that's a planted question, because we just put together an R01 to study the lean interventions in the care centers, and I think that's going to be really exciting. Oops. If you look here, this is Andrea Silver, and she's done a lot of work, actually devoted, one of her passions is in increasing increasing representation of in clinical trials and addressing disparities of care. And she's done a number of things, including that grant, the initial grant called Own It, which was Oncology works with New Haven, getting community representatives to weigh in on what kind of research is done at Smilo, and building those relationships. I think that our latest cancer grant has been incredibly, there's been a big focus on trying to increase representation of folks in our clinical trials, and that certainly is a focus for us.
Right, that's wonderful. One more question, and then we'll move on. Someone comments, it's amazing how you've built these tumor boards even before anyone knew what Zoom was. So now that we have Zoom and everyone can Zoom from their phone, from their watch, can we use this technology to further integrate, multimodality care, subspecialty care? With you showed us 55 or so doctors around the state. Are we using these tools of telehealth to do even better now to integrate our care?
Yeah, I mean, I think that with COVID, we've really we toggled up to over 50% of use of an adoption of telehealth during last spring, and I think that we have initiatives on next day access and improving access that we can utilize telehealth for, and certainly within our multi-D clinics, we're thinking about doing that as well. I think there's a lot of innovation, and I'll mention, again, Melinda talked, I didn't talk about the non-therapeutics, but we certainly have used the care centers as places to participate with the smoking cessation Joe Biden Moonshot initiative, as well as collect samples for Stephanie Halene's MDS registry and attempts to understand the science behind that. So I think there's just no end to what you can do with the resources and the team that we have.
Great. Well, thanks, Anne. Wonderful talk, and again, congratulations. So we have a second speaker. It's Dr. Francesca Montanari. Dr. Montanari is an assistant professor of clinical medicine in the hematology section and cares for patients with hematologic malignancies at our southernmost care center in Greenwich. Dr. Montanari recently joined Yale from the New York Presbyterian Hospital, Columbia University Medical Center, College of Physicians and Surgeons, where she was assistant professor of medicine and experimental therapeutics in the Center for Lymphoid Malignancies. Dr. Montanari received her medical degree from the University of Pavia in Italy, where she graduated magna cum laude and completed both her residency and fellowship at New York University School of Medicine, where she was awarded the Fellow of the Year Teaching Award. She served on the Institutional Review Board Committee and as director of the Institutional Lymphoma Tumor Board at Columbia University, and she is part of the steering committee of the Lymphoma Research Foundation New York Lymphoma Rounds. We're so lucky to have been able to recruit Francesca recently, and she's going to talk to us now about post-transplant lymphoproliferative disorders. Francesca.
Thank you for the introduction. So I'll share my screen. Okay, so good afternoon, everybody. I will review today post-transplant lymphoproliferative disorders. So here's my disclosures. So we will review together how PTLD are classified according to the most recent WHO classification, the epidemiology, the risk factors, the timing of onset, prognosis, and therapeutic options, including current treatment paradigms, ongoing clinical trials, and future directions. So let's start with the classification. Under the revised 2016 WHO classification, post-transplant lymphoproliferative disorder are classified under the immunodeficiency-associated lymphoproliferative disorders, along with lymphoproliferative diseases associated with primary immune disorder, HIV infection, and other iatrogenic immunodeficiency. By definition, they are any lymphoid or plasmacytic proliferation that develop as a consequence of immunosuppression in a recipient of a solid organ or stem cell allograft. It is considered a PTLD. And based on the new classification, the revised classification, PTLD include non-destructive PTLDs, further subclassified into plasmacytic hyperplasia, infectious mononucleosis-like, and florid follicular hyperplasia, which is a new entity under the new revision. Polymorphic PTLD, monomorphic PTLD that comes into the B-cell neoplasm and T-cell neoplasm, and classical Hodgkin lymphoma. So PTLD, non-destructive. These diseases are classified based on the histopathology major findings and the cell prevalence. There is usually preservation of the architecture, and these are polyclonal B-cell proliferation by immunophenotype and genetic studies. They're typically BV positive. They're responsive to immunosuppression reduction in most of the cases, and they are usually seen in kids, so in the pediatric population. So we do see on the bottom an example of plasmacytic hyperplasia with preservation of the architecture of the lymph node and infiltrates of abundant plasma cells. PTLD polymorphic, this is an entity that is characterized by a heterogeneous mix of immunoblast plasma cell and different sized lymphocytes. The architecture is usually effaced. These are mostly polyclonal, but presence of monoclonal B cell have been described and detected by immunophenotype and genetic tool. They're mostly EBV positive, and some of them have BCL6 somatic hypermutation. So here's an example of architectural effacement on the left with associated to a large area of necrosis, and on the right, variably sized and shaped lymphoid infiltrate. Monomorphic PTLD, those are the ones that do fulfill the criteria for non-Hodgkin lymphoma or plasma cell neoplasm. Small B-cell lymphoma are not designated as PTLD, with the exception of the EBV-positive extranodal marginal zone lymphoma that usually arise in the cutaneous or subcutaneous tissue. And this is because their standardized incidence ratio is not different than in the regular population, and they're not thought to happen as a consequence of the immunosuppression. Besides those, any other kind of non-Hodgkin lymphoma is considered a PTLD. So the architectural effacement is usually present. Immunophenotypic and genetic features are typically recapitulating what we do see in the immunocompetent counterpart. And here I included an example on the left of diffuse large B-cell lymphoma infiltrating a lymph node. And on the right, there is an example. This is a renal allograft biopsy with showing hepatosplenic T-cell, gamma delta T-cell lymphoma with the characteristic infiltration of the small blood vessels. Finally, classical Hodgkin lymphoma has also been associated and described in the setting of post-transplant and is considered to be a PTLD. It fulfills the criteria for the Hodgkin lymphoma that we do see in the immunocompetent population, but it's typically mixed cellularity. It's always EBV positive, and we do see that predominantly in the renal transplant recipients. Therapy is treated like the Hodgkin lymphoma in the immunocompetent counterpart. And here an example of a red Stemberg cell on the bottom, surrounded by an inflammatory background of lymphocytes and eosinophils. And this is a typical red Stemberg cell with a CD30 positivity. So very, very heterogeneous group of diseases. So how frequent are these lymphomas? So we do about 40,000 transplants every year in the United States, and PTLD is the second most common malignancy in this patient population behind non-melanoma skin cancer. So it accounts for 21% of all the cancers in recipients of solid organ transplant, as compared to only 4 to 5% of the cancers in the immunocompetent population. The incidence has increased over the past 2 decades, and this is for a variety of reasons. The increased age, the older age of donor and recipients, new immunosuppressive treatment, the introduction of the haploidentical stem cell transplant, and improved awareness of the disease and diagnostic tools. So after a solid organ transplant, the risk of developing a PTLD varies for over 20% to 0.8%, depending on the organ transplanted, multivisceral and intestinal being associated with higher risk, followed by lung, heart, liver, pancreas, and with the kidney being carrying the lower risk. For hematopoietic stem cell transplant, the risks varies based on the HLA, degree of the HLA matching, and the need for T-cell depletion. So it is highest for haploidentical with a T-cell depletion, 20%, and it goes down to 3% in recipients of match-related donor hematopoietic stem cell transplant. So what do we know in terms of risk factors besides the type of the transplant, of the transplanted organ, or the type of allogeneic stem cell transplant? For recipients of solid organ transplant, it is an established risk factor, the degree of EBV mismatch at the time of transplantation, with the recipients being EBV negative and the donor EBV positive. Also, the intensity of the induction immunosuppression treatment and the duration of maintenance therapy, including increased need of treatment due to graft rejection episodes. There is a strong evidence associated with the use of certain immunosuppressive drug, in contrary with others that are less associated. And weak evidence of risk is associated with infectious diseases, non-EBV infection, for instance, and other characteristics, genetic characteristics or underlying comorbidities of the host. For hematopoietic stem cell transplant, recipient age seems to be the biggest risk factor for development of these diseases, and the conditioning regimen. Also. So in terms of timing, typically PTLD arises early in the setting of hematopoietic stem cell transplant and later in the setting of a solid organ transplant, but is not really that predictable. We consider an early onset if the PTLD arises in the first year after the transplant, and a late onset if it arises a year later, starting 1 year after the transplant. And the reason the pathogenesis is associated in the early onset to an acute EBV infection or a reactivation of the EBV virus in the setting of a reduction of the anti-EBV cytotoxic T-cell lymphocytes. Usually early PTLD are EBV positive, and frequently there is the allograft is involved. In the late onset, there have been many hypotheses. So a hit and run EBV infection where the EBV then resolve and lymphoma keeps developing. Other viruses besides EBV has been hypothesized as playing a role, such as CMV. A persistent antigenic stimulation done by the allograft and lymphocyte deregulation in the setting of a chronic immunosuppressed state. These are usually more likely with an extranodal involvement, not necessarily involving the graft, and the monomorphic subtype is the most common. So what do we know about the prognosis of this disease? Data regarding prognosis are mostly from single institution retrospective analysis. And during my time at Columbia University, I worked on setting up a tumor bank for this disease with pathological specimen linked to clinical information. And this is what we have learned from the analysis of 120 patients. This is the largest series published so far on this specific disease. Interestingly, most of the clinical features that we think might predict an outcome and might have an impact on the overall survival did not correlate with overall survival in our patient population, including the subtype of the PTLD, the decade of diagnosis prior or after the introduction of the rituximab, the kind of organ transplanted, EBV status, graft involvement, and extranodal involvement or stage of diagnosis. So using a recursive partitioning model, we separated patients recursively at each step into two distinct groups based on the variables that provided the maximal separation based on survival. And using this model, we were able to identify, based on age, CD20 expression, and ECOG status, 4 groups that were well separated in terms of overall survival and with an even number of patients. And in the low risk group, we can see that the median overall survival was not reached. Those were essentially mostly pediatric patients with a good performance status, whereas in the very high risk group, elderly with a poor performance status, and essentially all patients with a CD20 negative disease, the median overall survival was as short as 1.3 months. So what else we have learned? We know very well that T-cell lymphoma have a much worse prognosis than B-cell lymphoma in the immunocompetent population. But what is the behavior of T-cell PTLD is not well known due to the rarity of these diseases. So we did analyze in our series of monomorphic PTLD the differences between B cells and T-cell PTLD, and we do see that they sort of recapitulate what we do see in the immunocompetent counterpart in terms of prognosis, with a median overall survival being very low for the T cell and compared to the B cell monomorphic PTLD. Also, we did observe that the time of the median time to onset was much longer for T cell, 9 years compared to 3 years for the B cell type, and all T cell PTLD in our series were EBV negative. Another thing that we have also learned is that the importance of bone marrow of staging and the incidence of bone marrow involvement in PTLD. It is very common. In our series of patients, 23% of monomorphic PTLD had a bone marrow involvement compared, and in the T cell subtypes, 50%. Also, polymorphic exhibited a very high bone marrow involvement, 15.7. All the cases of polymorphic where bone marrow involvement was detected, this resulted in upstage of the disease. A bone marrow involvement was associated with a poorer outcome. So we did compare the incidence of the involvement of the bone marrow involvement in monomorphic PTLD compared to de novo diffuse large B-cell lymphoma and HIV diffuse large B-cell lymphoma patients diagnosed during the same time frame at our institution. And we do see here that monomorphic PTLD involvement compared to the HIV positive diffuse large B-cell involvement. And this suggests that immunocompromised state, regardless of the etiology, viral associated or iatrogenic, maybe is a major risk factor for dissemination to the marrow. Finally, we analyzed last year, actually 2 years ago, and this was presented at ASH in 2019. We did analyze the data regarding the cell of origin and the impact of treatment on the outcome of diffuse large B-cell lymphoma, the PTLD type. And in our series, non-germinal center was more common than germinal center. I just want to highlight here that, as previously reported, non-germinal center PTLD is usually EBV positive versus germinal center is usually EBV negative. Clinical characteristic, organ transplanted, immunosuppressive treatment, time of onset was not different in these two subtypes. There is a trend suggesting a better outcome, a better PFS and OS in patients with germinal center compared to non-germinal center, mirroring the outcome in the immunocompetent population. And our EPOC did not improve overall survival or progression-free survival where compared to our CHOP, but did not resulted also either in an increased toxicity. In our series was extremely low. Only one patient died in each treatment group. So the current challenges for PTLD are that this is an uncommon disease. As we saw, there is a big heterogeneity in the type of PTLD. There is heterogeneity in the patient population, in the allograft or hematopoietic stem cell transplant, and immunosuppressive treatment that they receive. There is a high mortality rate that is associated with the chemotherapy, and this is usually linked to the increased risk of infection that we do see in this patient's population. And unique to this patient population is the risk of graft failure. So currently, general principle of treatment include immunosuppression reduction. I just want to mention that the only prospective trial that utilized immunosuppression reduction as part of a sequential treatment for this disease on a very large sample of, on a very large number of patients, 160 patients, showed a 40% incidence of acute graft reaction. So typically in the adult population, immunosuppression reduction is utilized at the same time of other interventions, such as rituximab or a combination of chemotherapy. Surgery or radiation therapy, unlikely what we do see in Hodgkin and non-Hodgkin lymphoma, is a well-established treatment for stage 1 disease, PTLD. And in the relapsed and refractory setting, there are adaptive immunotherapy utilizing EBV-specific cytotoxic T cells, and high-dose chemotherapy with autologous stem cell transplant have both been explored. So there are only few prospective trials, primarily on polymorphic and monomorphic B-cell PTLD. And all the top 4 trials here use the rituximab as a single agent with a good overall response rate and CR rate, but not exciting overall survival due to early relapses. The best results, they have been achieved utilizing either a sequential treatment or a risk-stratified sequential treatment. And this is the PTLD-1 trial. That is the largest phase 2 trial ever conducted in this patient population and reported by the German study group. So we'll review the results of the PTLD-1, the risk-stratified sequential treatment. This was published in JCO in 2017. Patients were with a newly diagnosis of PTLD received an induction treatment with rituximab, and then based on their response, they received consolidation with rituximab alone, or they were escalated to R-CHOP. 152 patients were enrolled. Again, this is the largest study in this disease that has ever been conducted, and we do see that a quarter of them, after the initial induction with rituximab, achieved a CR. and these were the patients that did not receive any cytotoxic treatment. The overall response rate was 88%, CR rate 70%. Median duration of response was not reached, and the median overall survival was 6.6 years. Treatment-related mortality in this study was 8%, which is the lowest reported in this patient's population. And this has been attributed to the fact that a quarter of the patients were spared cytotoxic chemotherapy. So what's new in PTLD? Recently, over the past 5 years, it has been more and more recognized that PTLD tend to be CD30 positive. So this is a study by Vez and others that show that out of 108 patients with PTLD diagnosed between 1994 and 2011, there was 85% of these patients expressed CD30, including 81% of the diffuse large B-cell lymphoma. This is very peculiar to the PTLD. Because in immunocompetent diffuse large B-cell lymphoma, usually CD30 expression is probably less than 20%. And not only they demonstrated a high CD30 expression, they also demonstrated that it was associated with a better outcome. So why is this interesting or important? We now have a drug that targets specifically CD30. Brentuximab vedotin is an antibody drug conjugate that binds to the CD30, and once it's internalized, release monomethyloristatin E, which is a microtubule disrupting agent, which end up like causing apoptosis. As we all know, brentuximab vedotin is now approved with various indications in Hodgkin lymphoma and anaplastic large cell lymphoma. So in 2019 at the ASH meeting, the results of this phase 1/2 trial of brentuximab vedotin plus rituximab as frontline treatment for patients with immunosuppression associated lymphoma were presented. And this was a very small study, 22 patients with previously untreated immunosuppression associated lymphoproliferative disorder, including 16 patients were PTLD, post-transplant lymphoproliferative disorder. Patients who received an induction where rituximab was given in combination with brentuximab vedotin, and patients were restaged, and according to their response, they either received more rituximab, brentuximab vedotin as consolidation and maintenance, or if they had progression of disease, were removed from the study. Again, a small study, very short follow-up, but encouraging result with a very high overall response rate and CR rate of 60%. So I'm very excited to announce that that we're about to open a phase 2 trial for this patient's population here in the Yale network, and this is going to be a trial in collaboration with the Mayo Clinic and with the UVA. So it's a phase 2 trial where patients with post-transplant lymphoproliferative disorder, CD20 and CD30 positive, which essentially is the vast majority of PTLD, will receive an induction treatment with rituximab and brentuximab vedotin, and then based on the response at PET-CT after induction, they will receive more of the same treatment, and they will be spared of cytotoxic treatment, or will be escalated to rituximab, brentuximab vedotin, and bendamustine for a total of 6 cycles. Primary objective of the study are overall response rate, complete and partial at the end of the treatment, and PFS. Secondary objective intend to explore the overall response rate at the end of the induction phase, which include brentuximab vedotin on top of rituximab, duration of response, and overall survival. And we're planning to also deep dive into the frequency of infection, peripheral sensory neuropathy, the rate of graft rejection, and treatment-related mortality. Exploratory studies have the aim to identify new biological and genetic markers that might be predictive to response resistance to this therapeutic combination. So I'm going to leave you with this last slide. Future strategies, and this is a list of the clinical trials that are currently about to recruit or recruiting for this for post-transplant lymphoproliferative disorder. This top line is our study that I just mentioned, and we're about to open here at Yale. And then there is, I just want to highlight this, a second study is a study that follows up the Ptld1 trial from the German group, where they're where they're integrating the IPI score and the organ transplant to further risk stratify patients after the induction with rituximab. And they have substituted rituximab sub-Q to the regular rituximab that they used in the Ptld1 trial. Another trial that I would keep an eye on is the rituximab plus acalabrutinib trial that is not yet recruiting and is going to be done in Cleveland. And besides this 3 trial, which address the untreated population, in the refractory setting, there are a lot of trials with adoptive T-cell treatment. And with this, and this is it. So thank you for your attention.
Thank you. That was a wonderful talk, and it's great to see that you have a trial, and I guess it's open in Greenwich, or will be. So very well linked to the first talk we heard from Anne. Do we have any questions or comments? We're just about at time, but we might have time for 1 or 2 if there are any. Are you seeing a lot of this in your practice right now, Francesca, in Greenwich?
I currently have 1 patient, which is a lot considering that I've just started 2 months ago. So we typically used to have Columbia as a big transplant center, and we were seeing a lot of these patients, but to say a lot was about 20-30 cases per year, just to put this in context. So this is a rare disease.
Right, but as we grow Greenwich as an expert site, for these types of diseases, you'll draw more and more from Manhattan, and where I'm sure there are many post-transplant patients. Francine Foss has a question. She asks, any role for checkpoint inhibitors in these EBV-driven tumors?
This is a very good question, and I think that due to the peculiarity of these patients' population, which are recipient of hematopoietic stem cell transplant or solid organ transplant, there is a lot of, we're very worried about causing either graft reaction or graft versus host disease. So I'm not aware of any study utilizing checkpoint inhibitors in this specific patient population.
Okay, maybe I see a study in the making, maybe an investigator-initiated trial. Well, Francesca, that was great. Thank you so much. Welcome to the group. It's great to have you. And this will end Grand Rounds for today. I want to thank Renee and her team for helping get this set up, and I hope everyone has a good rest of the day. We'll see you soon.
Thank you.
Thanks, everyone.